during the meeting, you can control the mute function on the Hangout. We kindly ask that only those who are speaking to the group unmute the device. For the board member, please reserve the question until the end of the presentation or may ask in the Google Hangout meeting chat. For public comment, if you would like to provide public comment, COI must be on file. Please send us an email at medicaidpharmacy@utah.gov. For attendees that are not the member of the board, please enter your contact information in the Google Meet chat or send your information to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after our meeting to help us improve our process moving forward. Thank you. With that, I leave the rest for Dr. Cannon.
Good morning, everybody. I apologize for the background noise. Unfortunately, I'm down. So that will call the meeting to order. Everybody should have received a copy of the minutes.
Hi, we hear a lot of noise background from your call.
All right.
I'm so sorry, but it's really hard to be hearing with the noise background. Would it be okay? Do you want to try again?
Why don't you run this one?
It's the same.
Let's go ahead and why don't you run the meeting without
Yes, I can do that. I can conduct the meeting. Thank you. So first, business, can I have the motion to approve the minute or any edit to the minutes, please? To the meeting minutes of last month.
to approve, and it looks like Kumar's got the second.
Thank you. All in favor?
Aye.
Aye. Any opposed? Any abstention? All right, motion passed to approve last month's minute. The next item is P&T committee update.
Good morning. So next week, we will be reviewing non-steroidal treatments for atopic dermatitis. This includes both topical and systemic treatments. There's been a lot of development in this area and seems to be a fair amount of excitement around it. We will also have our annual training with the Assistant Attorney General, Tony Patterson. And that's what we have going on in P&T next week.
Thank you, Brian. Next is housekeeping. Jen, would you like to speak?
Sure. So I was asked to make an announcement today about my position change that occurred last Monday. It was announced that the governor has appointed me as the Medicaid director, and I've officially accepted this role, and my Senate confirmation hearing is actually today. So once I'm confirmed by the Senate, I will hopefully be named the official Medicaid director. How that plays with my role as pharmacy director, I will continue to be the pharmacy director at least through July when the consolidation is complete, and we'll stay tuned with next steps on that. I did want to thank this committee for your commitment to Medicaid members and to our program and to providing excellent input and guidance to what we aim to accomplish through our pharmacy services. and it's been a pleasure working with you. With that, thank you so much.
Thank
You're
you, Kim.
awesome. You're gonna be great.
Thank you.
So next item is the codeine use in children review.
Good morning. Okay, let me see if I could pull my slides up for you here. Okay, can everyone see those? I think they're up. So today we are reviewing codeine use in the pediatric population and the FDA's safety initiatives over the years. I'll first remind you about codeine metabolism, which is pertinent to its safety profile. Codeine has minimal affinity at the mu-opioid receptor. The main active metabolite thought to be responsible for its effect is morphine. In normal metabolizers, about 5 to 10% of the codeine dose undergoes CYP2D6 metabolism to morphine. The majority of the codeine dose undergoes UGT conjugation, and a small proportion undergoes CYP3A4 metabolism. Safety issues with codeine largely relate to population variability of CYP2D6 activity, particularly the ultra-rapid metabolizer phenotype, where toxic concentrations of morphine may occur following usual doses of codeine. In contrast, intermediate or poor CYP2D6 metabolizers may experience diminished or no therapeutic effect from codeine. The 2020 Clinical Pharmacogenetics Implementation Consortium guideline recommends against the use of codeine and tramadol in patients who are predicted poor or ultra-rapid metabolizers based on CYP2D6 genotyping. Drugs that inhibit or induce CYP2D6 or 3A4 may produce clinically significant drug-drug interactions. There is a black box warning on codeine products to avoid such combinations. Another potential interaction to be cautious of is use with P-glycoprotein inhibitors. Animal models suggest that inhibitors of PGP could potentiate opioid effects by increasing morphine in the CNS. So there are two key FDA safety reviews that assess pediatric utilization of codeine in adverse event cases. During the 2012 review, the most well-documented cases of life-threatening respiratory depression were among the post-tonsillectomy or adenoidectomy setting, which included 8 codeine-associated deaths. This led to the contraindication for use of codeine following these surgeries in any pediatric patient. These surgeries are used to treat recurrent tonsillitis and obstructive sleep apnea, or OSA, but because they do not immediately correct respiratory insufficiency related to OSA, individuals can still be vulnerable to respiratory depression soon after surgery. In recent clinical guidelines, there is a strong recommendation against the use of codeine in those under 12 years of age following these surgeries. An updated review in 2015 identified a total of 64 pediatric cases among the FAERS database with serious respiratory depression related to codeine use. 24 of these cases, which include the cases I mentioned on the previous slide, were fatal, with the majority of occurring in patients younger than 12 years of age. It was estimated that about 2 to 3 million pediatric patients had received a codeine outpatient prescription per year between 2010 and 2014. In 2014, 56% of these pediatric patients were below 12 years old. So the FDA added a contraindication to all codeine prescription products for use in children younger than 12 years of age. Rationale in the codeine product labeling now states that children below 12 years old appear more susceptible to the respiratory depressant effects of codeine based on these case reports, and especially if risk factors for respiratory depression are present. So there's also a black box warning that was added to avoid codeine use in adolescents with potential risk factors such as obstructive sleep apnea, severe lung disease, postoperative status, obesity, neuromuscular disease, and concomitant use with other respiratory depressants. In 2018, the FDA modified the indicated age for use of codeine and hydrocodone containing antitussive prescription products. Codeine prescription antitussives are now labeled for use in adults for relieving cough associated with allergies or the common cold, and exclude the previously recommended pediatric dosages. Rationale provided in product labeling states that the benefits of symptomatic treatment for cough associated with allergies or the common cold do not outweigh the risk of codeine in pediatric patients. The FDA's announcement of this label change also noted that for cases where pharmacologic treatment is necessary, alternative agents such as dextromethorphan and benzonatate are available. This slide summarizes practice points related to pediatric cough. The American Academy of Pediatrics described that acute cough from respiratory viral infections is short-lived and can be alleviated with fluids and humidity. They also pointed out that suppression of a wet cough could cause further complications. The American College of Chest Physicians has recommended against the use of codeine for the treatment of acute cough in patients 14 and younger. They suggest honey for common cold symptoms, but point out the Cochrane systematic review finding that honey does not appear to be more effective than dextromethorphan. For chronic cough defined as a daily cough lasting greater than 4 weeks, the ACCP described that children need to be carefully evaluated for underlying respiratory or systemic disease states. The application of symptomatic treatments for cough is only mentioned for the management of nonspecific dry cough that is not due to an identifiable disease, where it appears that a trial of a medication could be appropriate. Codeine is subtly listed among possible treatments for nonspecific cough, but with any symptomatic treatment, authors highlight the importance of close follow-up and discontinuing medication if there is no effect on the cough. During an expert roundtable meeting with the FDA in 2017, representatives of key professional societies highlighted that a cough suppressant may be considered if cough is causing clinical consequences. Listed on this slide are the non-codeine options that the panel proposed for acute irritant cough. In 2020, the chest expert cough panel pointed out that research gaps regarding complications associated with coughing. After compiling serious complications associated with cough, the panel advised that the impact of cough on the individual should not be trivialized, as cough is not always an inconsequential problem. Regarding pain management, the DHHS Best Practices Task Force has emphasized that health systems must consider the pain management needs of children. As an example, they advise protecting access to responsible use of opioids rather than arbitrarily restricting access, especially for sickle cell disease-related pain in children. In other scenarios of acute pain, guidelines or expert reviews have highlighted that NSAIDs can be considered first line in many cases related to postoperative pain at discharge or mild to moderate musculoskeletal pain. Though a couple RCTs suggest that some patients with musculoskeletal injury may require rescue therapy due to inadequate response with NSAID therapy alone. The American Pediatric Surgical Association endorsed the FDA warnings and contraindications for codeine. For otolaryngologic surgery, guideline authors have mentioned that if there is insufficient response to NSAIDs and an opioid is required, oxycodone or morphine appear as more suitable options rather than codeine. While there is considerable treatment need for chronic pain in children, from high-quality RCTs is lacking for any pharmacologic intervention, including non-opioid options and opioids for pediatric chronic pain. Guidelines either recommend against codeine in pediatric patients younger than 12, or more generally recommend that opioids should be reserved for when other analgesics are insufficient. In guidance regarding specific pain etiologies or pain types, Authors have highlighted non-coding options. For example, for pain related to sickle cell disease that requires an opioid, morphine, oxycodone, or hydromorphone are considered. For neuropathic pain, agents such as gabapentin, amitriptyline, or topical lidocaine are typically considered first line. As for pharmacy utilization in the Medicaid fee-for-service pediatric population, during 2021, 34 pediatric patients filled a codeine acetaminophen prescription. 8 were under 12 years of age. 20 patients filled a codeine-containing antitussive liquid, and again, 8 of these were younger than 12. No pediatric fills were found over the last 3 years for codeine single ingredient tablet or codeine combination products with either butalbital, carisoprodol, or chlorpheniramine. Contrasted with 2016, 2021 is with considerably fewer pediatric fills of codeine products, which seems to suggest more judicious use of codeine more recently. Even so, PA could be considered to ensure use is for exceptional cases where other options have been exhausted or are inappropriate. It is also worth considering whether there is potential inaccessibility to non-opioids for cough, such as over-the-counter products, and if this influences prescribing of codeine. These alternatives.
Hey, Val.
Yeah.
I'm Valerie. It's Joe at the state. The third bullet point. I'm sorry to interrupt, but before you go on to the next slide, the third bullet point, no fills. Is that for all ages or just for pediatric under 18?
That's just for pediatric fills. Oops, let me go
Thank
back.
you.
Yeah.
Thank you.
Yeah, I only looked at pediatric fills for this project. So we can go ahead and move on here. So Utah Medicaid fee-for-service has an age limit in place for codeine guaifenesin cough preparations, and that's restricted to 12 years and older. You may also consider applying this age restriction for codeine promethazine as well. There has been pediatric utilization for codeine promethazine, some in children younger than 12 years of age. This product has an additional black box warning describing that children may be more sensitive to the additive respiratory depressant effect of promethazine when combined with CNS depressants such as codeine. Also in place for Utah Medicaid fee-for-service is the requirement for prior authorization when prescribing a supply of more than 7 days of any short-acting opioid to pediatric patients. You may consider a drug-specific prior authorization for codeine pediatric use, including for shorter supply durations not captured by the PA already in place. Such PA could be designed to ensure that the prescriber has considered key safety issues, such as potential risk factors for respiratory depression, like obstructive sleep apnea, the labeled contraindications, potential drug-drug interactions, and that therapeutic alternatives have either failed, are inappropriate, or inaccessible for their patient. Additional case-by-case considerations may include consideration for patients already on codeine that have not had adverse events, and those with CYP2D6 genotyping that can guide prescribing. And that's all I have for you. Thank you very much.
Thank you, Dr. Gonzalez. So I'm going to present our current policy and what is our proposed considerations. So as of right now, our current policy is we are requiring the prior authorization for the use of codeine product, including C2 and C3, in children less than 18 years of age for a quantity beyond 7 days supply. That is the same with any other opioid policy right now. Any product that include butalbital or codeine product are restricted to 18 years of age or older only. Additional restriction for codeine, guanfacine, and phenylephrine in chlorphenamide codeine, pseudoephedrine codeine, COP reparation is restricted to 12 years and older only. We have no age restriction for any promethazine and codeine product. Fee-for-service utilization, as Valerie has presented. In 2021, 34 fee-for-service patients under 18 years of age used any Tylenol and codeine product. Within those, a patient under 12 years of age, 26 of them is between 12 to 18 years of age. 20 fee-for-service patients under 18 years of age have used any codeine-containing antitussive product, cough and cold. 8 of them are under 12, and 12 of them are between 12 and 18 years of age. So for policy consideration, we propose 2 of the options to the board and would like the input from the board. For the option 1, we would like to restrict on codeine product, including any analgesics and antitussive to adult 18 years and up only. Similar to any exception to this policy, prior authorization is required if the provider and the patient would like the product. We will be utilizing the opioid and opioid benzodiazepine combination PA, with the criteria is clinical rationale for the use of analgesics codeine product for children between 12 to 17 years of age. So we ask that this population is not to be used post-tonsillectomy or adenoidectomy, or in adolescent patients with obesity or obstructive sleep apnea. There's no drug-drug interaction, and patients have tried and failed appropriate alternative analgesics product, as I mentioned in the presentation before. For option 2 is we only restricted antitussive codeine product to adult 18 years and up, as in the label. Similar to any exception to policy, PA is required. We will be utilizing the medication covered exception for off-label criteria. But for analgesics codeine product, we only allow for patients 12 years and up. We will restrict it for under 12 years of age. But for 12 years and 17 years of age, we will not allow to be used post-tonsillectomy, adenoidectomy, or in adolescent patients with obesity or obstructive sleep apnea. And Dr. Weinstein have a question. Do we know if we have any related death? Val, do you have an answer for that? Or do you mean within our population or in overall, Dr. Weinstein?
Yes.
In Medicaid or?
Yeah, with the numbers we presented for our prescribing.
Not that we're aware of.
I thought so. Thank you.
Yeah. And that is our 2 of the policy consideration option for the board.
Can you help me a little bit with
My apology, Eric, is we cannot get what you were saying. Sorry about that.
Kumar, you're on mute if you're trying to speak. The controls for the mute are at the bottom of the screen. There's some round controls. The one on the far left is to turn on and
For Eric, he asking how many could cover under fee for service. Give us a moment, we can get the answer for that one.
About 200. Do you mean total in Medicaid? I think it's 240,000, something like that, or do you mean relative to this policy?
I could just make a couple of comments. I know that during this period of time, since I've been credentialed at Primary Children's as a pain medicine specialist, I know that they had implemented policy to reduce opioid prescribing in general. And so I think one of the contributors to reduction probably in the codeine prescribing was within the overall context of reducing opioid prescribing. And so that's just an observation. And also probably part of the general context of clinicians being more conscientious in looking for non-opioid alternatives to acute and chronic pain management. So I think, these trends we're seeing whenever we look at opioid prescribing in the last few years, and those are very positive, of course, for better safety. The couple things about codeine in general. Thanks for this excellent and very detailed review. I know you only put the highlights up for us for our presentation this morning, but for those of you who had time to read the documentation, there's excellent detail in there, particular for this drug. We know a lot about it, and it's an old drug, of course, and there's a lot of conventional use. And I think a lot of the products have been around for a while, and there's some habitual practice. And so some of this might be still trying to get to folks who might just be prescribing out of old prescribing habit, like we do sometimes have to do education and write certain guidances because people are doing things out of habit, out of prescribing habit. I think the only thing that comes to my attention is the one product that we have here that's a promethazine codeine combination that has no restriction to it, and I was curious how that might be considered exceptional, because that looks to me like it would have similar risks as the others do. So I would be wanting to make sure that we have consistency with whatever we have in place. I just as an opioid prescriber with a lot of experience both in adults and children, codeine is a drug we don't generally use unless we have a particular reason to use it in chronic pain management and in other symptom control. It's a drug we use a lot for diarrhea management because clinically we think it tends to cause more bowel slowing. So it does have a niche in pain and symptom management, but I think we want to consider if there is a way for us to put some things in place to improve safety, particularly in the pediatric population. I do believe we can do it. Eric is saying the number of kids is small and maybe not more action is needed, but could we go back and look at what's the issue with the codeine promethazine? I think that's the only thing I have. Yeah. Okay. Would folks like to? I know I just said a lot, but probably not much of it was constructive. Just question about the promethazine codeine. Thank you.
I would just like to comment based on what Dr. Weinstein said. The promethazine is an antipsychotic. It can cause tardive dyskinesia with long-term use, and it also does prolong the QT interval, especially when it is combined with other drugs that do so. It's really unclear to me why that particular combination of promethazine and codeine are sort of not included among all the other coating products.
Because it does have those added risks that Dr. Siegfried pointed out. I would agree. It might have even more considerations for safety than the others.
Thank you, Dr. Siegfried and Dr. Winston. So yes, we are proposing to put the age restriction to all of the antitussive codeine product, including the promethazine and codeine, in addition to any of the codeine, guanfacine, and any of these cough and cold product as well. To right now it's 12 years of age and older, but we're thinking of going to 18 years of age and older to be in accordance to the new labeling package insert. Yes, Kuma?
Can you hear me now?
Yes.
Okay, so nowhere in the presentation I heard anything about the dosage, the amount restriction, or one of those kind of things. Did I miss something?
That was a good pointing out. Val, if you want to speak up.
I do have information about that in several tables in the report. So now the antitussive codeine prescription products, those don't have pediatric dosing on them anymore. But in some states, there's OTCs, like you have a codeine guaifenesin OTC in some states, and those have pediatric dosing on them still. So so you could go back and look at old package labels or the OTC labels to get an idea of what the dosage would be, and it kind of depends on what other co-formulated agents are in there. And then with analgesic dosing, that's usually based on weight. So but overall, I was finding that maybe 60 milligrams per dose is the highest, but in general, it's about 0.5 milligram to 1 milligram per kilogram per dose every 4 to 6 hours for analgesic dosing. That's the historical dose I've seen, but that's no longer included on the new package labels.
So you don't think there's a need to mention that, right?
I do have dosing in tables if Medicaid does want to restrict by dose as well. I think that could be an option too.
So whatever the experts want to do. Thank you.
Any other comment?
Then, just a quick question on the prior authorization form itself. Will that form include some of the policy that was presented in the monograph that Val presented? It looks like the current proposal is to change the policy from 12 years of age to 18 years of age. But will the prior authorization look at some of the kind of restrictions for use or criteria for use in the prior authorization form? Does the form cover that? I just couldn't remember.
Yes, Neil. So so the proposal right now is to increasing the age of the cough and cold products, the syrup, to 18 years of age and up. And similar to any exception to policy, PA will be required, which we will be using the coverage exception for off-label criteria. For the off-label criteria, because all of the syrup for coughing product is only 18 years and up. So any outside of that age range will be considered off-label criteria, which will be requiring safety and efficacy. And a lot of those, we most likely won't allowing them because of the risks that we all well know, but we're still gonna use the PA just to allow access if the provider have enough clinical evidence that this benefit needs to be used for this patient. And we will take into the consideration of what Val have present.
Okay, cool. Thank you.
Thanks.
I think the bullet point here on the bottom is worded maybe backwards.
Yeah, I was just thinking that.
I think it should say restricting analgesic coating products to children over 12. Is that what we meant?
Yes.
Okay.
Yes, Val?
Oh, I just had a general question. As far as OTC, what's available OTC, non-coding antitussives, are those available to Medicaid patients? I didn't see options listed in the OTC list. Do providers have access, like if they were to need to treat a adolescent? Do they have access to OTC stuff like dextromethorphan or nasal saline and basic things like that?
Yes, I think Brian has that answer for us.
So with OTC products, we're limited in what we can, like what types of medications we can put as covered products. The state plan has specific classes of medications that we can cover among OTC products. There are a small number of prescription dextromethorphan containing products that are covered, but again, that is somewhat limited. Let me just check really quick. I want to look up benzonatate, which is another one that's sometimes used. And I think we have coverage of that, but I want to double check that real quick. Yes, we do have coverage of benzonatate, which is prescription, but it is an antitussive that we do have available.
Thank you.
You're welcome.
Any other comment, or can we have a motion?
Sorry, just one more question. So, is codeine restricted in any adult with obesity or obstructive sleep apnea, or we're only restricting it in adolescents with obesity and obstructive sleep apnea because of the pediatric data?
So when we're looking at this, the FDA label warning was specific to pediatric adolescents. So
got it. Okay, just got it. I just have to keep my keeping my facts straight. Thank you.
Yeah, you're welcome.
Are you looking for a motion?
I was going to move. We go with option 2 on PA.
I agree.
For
I'll second that.
In pediatric use.
Thank you. So the motion is to go with the policy consideration for option 2 to restrict the coughing product codeine to 18 years and up, and any analgesic codeine product to 12 years of age and up, with the option to PA for exception.
And Noon, just for the committee's benefit, Eric typed in for sure 12, but he could go to 18, just for those not seeing his comments in the chat.
Thank you.
And with the modification regarding restriction that Sharon mentioned earlier. The language.
to restrict unnecessary coding product to children over 12 years of age. Is what you meant? Okay. All in favor?
Aye.
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 Aye. Any opposed? Any abstention? Motion passed. Thank you, everyone. With that, let's conduct our business for today. We don't have the next meeting will be canceled. And in March, meeting for March will be canceled. We will send an email for April meeting. Can I have a motion to adjourn? Thanks, Kumar.
So
Second.
Second.
Thank you. All in favor?
Aye.
Aye.
Any opposed?
Thank you, everyone.
Thank you.
Thanks, everyone. Have a great week. The weekend is close.
Okay.
Bye.
Bye-bye.
Bye-bye.